Alright, buckle up, you badass motherfuckers, because today we're diving knee-deep into a gnarly-ass knee conditions that'll make you wince harder than stepping on a Lego in the dark. We've got a 30-year-old dude with anterior knee pain slamming the lower patella pole. No trauma or fever, just pure bullshit. Radiology showing a thick, pissed-off patellar tendon with edema creeping into the fat and patella tip. Subtle bone marrow edemas chilling in the medial femoral condyle. Plus an extra iliotibial band meniscal ligament being a sneaky fucker. Here's another slice, showing that this normal anatomical variation straightly connected to the lateral meniscus. And there's a mild joint effusion making it soggy as hell. Short and sweet. This knee's a hot mess. Peace out, legends. Alright folks, now we're cracking open this case discussion that's got all the juicy bits. Jumper's knee, some wild-ass tendon shit, and also with a freaky little anatomic twist called the AIML, accessory iliotibial band meniscal ligament. Let's fucking dive in. First off, Jumper's knee is no joke. We're talking a chronic insertional injury that's beating the crap out of the posterior and proximal fibers of the patellar tendon, right where it latches onto the inferior pole of the patella. This tendon's basically getting cooked from the inside out, and it's pissed. Why? Because it's taking a pounding from all that repetitive forced knee extension. Think basketball, volleyball, soccer, tennis, and track. You know, the sports where you're jumping like a goddamn maniac, hence the name. It's the tendon's way of saying, fuck this, I'm done. Now here's where the nerds start arguing. Some brainiacs reckon Jumper's knee is the grown-up version of Sinding Larsen-Johansson disease, like it's the same shit but in active adolescence, typically between 10 to 14 years of age or a cerebral palsy patient. Others, they're not buying it. They're calling it a mid-substance patellar tendinopathy, like it's some fancy internal tendon meltdown instead. Either way, this injury shows up looking thick and torn, like the tendon's been hitting the gym too hard. On a sagittal MRI, you'll spot it with a tendon thickness over 7 millimeters or some bright intrasubstance high signal intensity. It's like the tendon's glowing with rage, and I'm fucking here for it. Treatment-wise, we're keeping it chill at first. Conservative moves are the MVPs here. Limit the activity that's screwing your knee, then hit it with some exercise, and physiotherapy to whip that tendon back into shape. If that fails and shit's still broken, surgery's the last-ditch play, but nobody's rushing to the operating table. Now let's talk differentials, because the knee's a messy bastard. You've got Osgood-Schlatter disease, fucking up the tendon's hookup to the tibial tuberosity. Then there's Sinding Larsen-Johansson disease, playing its own game. Play as young version of Jumper's knee. Patellar sleeve fractures are in the mix too. Same age group, tearing off cartilage from the inferior pole with a little fracture fragment for flair. And don't sleep on infrapatellar bursitis, fluid signal chilling interior to the tendon like it's got no fucks to give. So there you have it, this Jumper's knee saga is a goddamn roller coaster of tendon torment, and we've dissected it like pros. Smash that like button if you're vibing with this cooked case, and let me know in the comments, what's your take on this patellar chaos? Let's keep the convo raging.